So good evening, everybody. Welcome to tonight's Topics in Trauma Nursing. This is session number 5 of Topics in Trauma Nursing, and we've got a phenomenal speaker here with us tonight to share his expertise on a special population in trauma that I think is always under measured, but certainly I think it needs to be given the gravity that the population deserves. So we're going to have a good session tonight. As always, thank you for being here. And, whether you're watching this live or you're watching it recorded, certainly do leave any comments in the comment section on YouTube that you might have. You'll also have an opportunity at the end to claim CE credit for participating in tonight's program. The CE credit button will remain active for about 1 week after tonight. So we're talking till really about the 14th of June. So anyone who watches this online certainly can claim credit if you are so inclined, and certainly feel free to share the link that you have gotten if you didn't participate in this live, and share it with any of your colleagues that you might be interested. If I can get my screen to move forward, that would be even better. Gonna work now for me. I'm on show mode real quick. Every once in a while, you have these great technical difficulties. Everything always runs great right up until the time you need it to go into show mode, right?
Yep, Murphy's Law.
All right, we're going to try this one more time and see if I got this problem solved. All right, boom. Should be back on my original screen, correct?
Yes.
All right, so let's see if we have got this kink worked out. Yeah, it's kind of hanging up on something here. So, all right, so let's do something else now. I'll share. Put mine there. And for some reason, you are just hanging up on me there. I just have to restart PowerPoint real quick. All right, we're going to go this one more time. Here's that. You should be seeing my screen once again.
Yep.
There we go. All right. So I guess we'll make this a take 2. Topics in trauma nursing. So for those of you that have not participated in topics in the past, a little bit about what we do and who we are. Basically, it's a quarterly educational offerings designed to bring cutting edge topics in trauma care to emergency and trauma nurses, predominantly in New Jersey. But you know what? If you're not in Jersey, that's even better. That's totally cool. I love to see us go multi-state or even worldwide with this. The goal is pretty simple. Just sit back, enjoy. If you have any questions, use the chat box to answer any questions you may have. But at the end, what we'll do is we'll have an opportunity for everybody to come online, ask any questions you want in real time. A lot of people sometimes like to kind of do this in a little bit of anonymity and ask questions in the chat box. So please don't hesitate to do that. All sessions are being recorded. They're going to be available on YouTube. If you look at the QR code at the bottom of the screen and you very quickly want to snap on that QR code, that will take you to the YouTube page, which houses not only topics in trauma care, but the companion program that we do called the Trauma Nursing Journal Club. So there'll also be a link available to this in the email that I send out to everybody afterwards to remind everybody to claim credit. And if you like tonight's session or you enjoy what you've seen online and you want to participate in our companion program, the Trauma Nursing Journal Club, please feel free to do so. You can email me at the information that I'll provide you at the end with my email address, and you can let me know if you're interested. Typically, anybody who signed up for topics in trauma nursing will automatically get ported into my list of email addresses that I'll send out to recruit you to be a participant if you so desire in the Journal Club. Our next topic session is going to be September 6th. It's going to be the Shock Index, an emerging tool for occult hemorrhage and trauma. This will be a reprise of a talk that I gave at the Emergency Care Conference that New Jersey ENA put on in Atlantic City in March. Got some very good feedback on it, so I think it's worthy to talk about this again. We did do a Trauma Nursing Journal Club on the use of pre-hospital shock index about a year ago. At that time, the shock index, or a lot that was available on the shock index, was pretty kind of low key, and that particular article focused on the use of the shock index in the pre-hospital setting. So what we'll be doing with this session is really kind of pulling it back and putting it in our court as trauma clinicians for us to take a look at it, look at some of the studies that have been out there, and why I find and why I think trauma resourcing in general is finding the shock index is really emerging as a very useful tool when it comes to predicting hemorrhagic shock in our trauma patients. So kind of the rules of thumb for tonight is go ahead and put yourself on mute. And right now, everybody is on mute except myself and Justin. Any questions, go ahead and enter them in the chat box, but we'll also have an open forum toward the end that will bring everybody up live. And if there's any questions you have or any comments you have, you can voice them at that time. All right, so I am thrilled tonight to have Justin Millisey here tonight. Justin and I have been working kind of offline on an article of similar content that congratulations, Justin. He's received word yesterday that it's going to be published in a future issue of the Journal of Emergency Nursing under the trauma section. This is good. Tonight's program will be excellent, and I certainly will push the information out to everybody when Justin's article gets published, and it's usually online for a very brief period of time that everybody can download it for free. I'll push out that information to you when the time is right, and you can have a good time not only listening to what he has to say tonight, but also take that article and spread that article around. Justin is a clinical editor with Elsevier. Our kindred spirit is there. I ran the continuing education group at Elsevier for a number of years. And so I have all my fond memories of working with Elsevier, and I'm thrilled to have Justin here tonight as well. In addition to that, Justin is extraordinarily multifaceted. Not only can you tell by the number of letters he has behind his name, but his resume really reads kind of hits me where I am, with somebody who's very interested in providing education for nurse clinicians out there. And he's kind of been there and done it all. And he's also one of the things that I don't have behind my name that I hope to get behind my name. Maybe next year I'll take the plunge for it. Will be the fellowship in ENA. So congratulations on that to you, Justin, as well. So, and requisite continuing education information for tonight. Justin does not have anything to disclose, but like all of us, I'm sure he wishes he did. But the continuing education information tonight is pretty straightforward. Continuing education is being provided by the Institute for Medical and Nursing Education, and IM&E is accredited as a provider of nursing continuing professional development by ANCC. And you will get 1 contact hour of credit for participating in tonight's program. And then at the end, I'll have a QR code and a link that I'll put in the chat box that will take you to a Survey Monkey evaluation. And you'll fill out the evaluation, give me your contact information, and we will send you a CE certificate post haste. So without further ado, I'm going to turn the board over to Justin. Give him control here. Let me see. Oh, I lost my list of participants. Bringing it back up. And oops, how about I not give it to myself? All right, boom. We should be getting the little host box momentarily.
I got it.
All right.
I will
Stop sharing my screen.
All right, let's go to. Okay.
Perfect. We're on.
Okay. Well, good evening, everybody. And thank you all for having me here. We're going to talk about a topic that is not only a very hot topic right now, but it's a topic that's very, very near and dear to me. And that is the care of the transgender or gender diverse population or patients. Special considerations for the trauma team is going to kind of be the focus of my talk tonight. So, you can't have a you can't have a talk without those objectives up there, right? So, we're going to talk about the incidence and common causes of injury in the gender diverse transgender patient, also the special considerations in performing a primary and secondary survey, and special considerations when performing those interventions. Now, I want you all to just kind of have a look at that picture that I'm holding up for you right now. I want you to keep that picture in your mind as we go through this journey about the patient who is transgender or gender diverse. I always ask somebody, okay, have you ever met anybody who you knew was transgender? That's almost kind of a trick question, because if you say no, you know what? That's probably good, because my point being is you may not know. And you may not know because these patients need to be treated and respected like any other patient, period. They do have special needs, but that's the bottom line. These patients need the same dignity, treated with the same dignity and the same respect as with any other patient. And if their affirming status or their gender status is really irrelevant to the reason that they're there, what injury, there's really no need to dig deeper to get more information about that. We're going to talk about that more in a minute. Okay, so I'm going to just start with a quote by a longtime friend of mine, Andrew Solomon, who said, "Gender is among the first elements of self-knowledge, and it can start as young as 3 years old in these kids." We talk, that's the self-knowledge, and we're going to talk also about some definitions of terms here. These definitions of term. Now, I'm going to tell you right off the bat that gender-affirming care is very, very fluid, and it changes every day. So these definitions change every day. And so, just when you think you kind of got your hands on the most current definitions and the most current best practice, that could change the next day. So always kind of keep that in mind, that this may be what they are today, but in a week, month, they could be something completely different. And we're going to go through each one of these here. Okay, so let's talk first about the sex assigned at birth. And the first thing I'm going to tell you all, it is not synonymous with gender identity. It is not synonymous with gender identity. And there are people who do believe it is synonymous with gender identity. So we talk about the sex assigned at birth, and that is the current recommended term. Sometimes it's referred to as birth sex, and both are appropriate. Sex assigned at birth, though, is the current recommended term. This is the genetic makeup. These are the chromosomes. This is where the person's got a Y chromosome, an XY, an XX chromosome. It's the biological makeup of that infant, that infant when they are born. As I sometimes it is referred to as natal sex or birth sex, which are also accepted. We talk about gender. That's the perception of that person's sex on the part of society. As a male, a man, a female, a woman, the perception. So when I say that that actually is one of the first elements of self-knowledge in these kids that are young as 3 years old, they're figuring out at this age that this is who I am. And sometimes I don't feel that this is who I am. I feel that I am someone else. We'll talk more about that here in a second. Okay, gender identity is that internal sense of self. As man, woman, both, or neither. It's kind of mind-boggling. And some of these terms and these definitions are going to kind of, they are mind-boggling. They're going to kind of boggle your brain here a little bit. And a lot of them are similar. But this is essentially what, and then as I say again, it is not synonymous with the biological sex. It's their sex assigned at birth. It is not synonymous with that. Develops by 3 and it remains relatively stable over a lifetime. Because, if once that child figures out who they are back then, that, I have these parts and I know that this is who I am, or I have these parts, but I don't feel like I should. That's pretty strong. And that will stay with them, pretty much for a lifetime. Gender expression takes it a little bit further. This is how the person will express their gender in everyday life. Okay, this is who I identify as. And so this is how I'm going to express myself, whether it is the clothing they wear, whether it is the activities that they like to do, whether it is the friends that they like to hang out with. This is how I want to express myself. This is who I identify as, and I'm going to express myself as this. When we get into transgender, these are the individuals who have a gender identity, but it is not fully assigned with, not fully with their assigned sex at birth. So this is the child who by 3 or so, you give or take, I know I've got these parts, but I don't feel, I don't feel like these parts. I would rather, identify or express myself the way that other kid who doesn't have these parts expresses themselves. And this, and this is where they start to kind of come into that. But there's many verse identities and expressions. It's not black and white. There's no one way to be transgender. In other words, if this is an assigned male at birth, and this boy really feels as though they are an assigned woman at birth or assigned girl at birth, they may not necessarily want to express themselves that way. They may want to express themselves some other way. And that's my point there, is it's not black and white. There are many diverse identities and expressions. And many, not all, do seek some type of medical or surgical affirmation, intervention to align their minds and bodies, whether that be gender affirming hormones or whether that be, surgical affirmation procedures. Now, I'm putting this up here just to kind of explain when you're thinking about the transgender man or you're thinking about the transgender woman, this is how, this is essentially what it means. When the transgender woman, for example, the woman part does not indicate, that does not insinuate, or it does not indicate their assigned sex at birth. It is who they identify as. Does that make sense? So the transgender woman would have been a male to a female. A transgender man or a trans man would be a female affirming to a male. Okay, so it always refers to who that person identifies as. And by the way, and I'm only putting those, I'm putting those little abbreviations up there just to kind of make a point here. Those actually are not fully recommended anymore to actually use that male to female or female to male acronyms. As I said, I'm just using that just to kind of make that point. Gender diverse. Now, gender diverse, that's the kind of that's a big umbrella term. It's essentially anybody, gender identities outside that gender binary structure. In other words, outside of the man, outside of the woman. That is being gender diverse, and there are many definitions under gender diverse. Non-binary. Okay, non-binary is a very common one. So non-binary essentially means, this, kind of falls outside of the traditional binary structure of girl, woman, or boy, man. It's just funny. It sounds exactly the same as that definition up there, but it makes it just a little bit more specific. Their gender identity falls outside specifically of that traditional binary structure, the traditional woman or the traditional man. We move further, the gender queer. Okay, gender queer very often can be like non-binary. So gender queer essentially indicates that these are the ones who fall outside the traditional gender binary of male and female, and some people use the term gender expansive. So gender queer and gender expansive are actually synonymous with one another. I know they all sound very much alike. And these, as I said, these terms could change. Gender fluid is a little bit different. If you think about the word fluid, right? Fluid, it's constantly moving. And that's essentially what this indicates. This is the person that feels like a mix of more than one gender, but they be more aligned with a certain one some of the time and more aligned with another one another part of the time. So one week they may kind of veer towards the gender of a man. And then after a couple of days, the water's kind of moving again. And then we have we identify with the gender of as a woman. And then a couple of days later, we identify as having no gender or having the gender of both or having the gender of neither. Oh, this is going to blow your mind. And we talk now, this is a relatively new term, demigender. If you think about the word demi means half. Okay, demi means half. And so this is where, you ready for this? This is where the person actually will identify with a portion of it, with a portion of that gender. So they identify with a portion of male and a small portion of man and a small portion of a woman. Okay, that's demigender. So if you think about that's half, it's partial. And so that's essentially what that's actually referring to. So it's a partial connection to the woman, a partial connection to the man, a partial connection to those who are non-binary. Bigender, you're all familiar with the term bisexual. Well, bigender essentially is, bi means two. So this is where that individual would be having that identity that combines two genders. Same thing when you think about bisexual. Their identity combines two genders. Maybe not necessarily man and woman, it could be man and something else, but that's bigender. Also, agender. You've heard the term asexual. Agender, a means, nothing, not, nothing. And so agender essentially is, and this is a person that identifies as having no gender at all, or who does not experience gender as a primary identity component. That's agender. Okay. Cisgender simply means the gender identity is consistent with the sex assigned at birth. That's cisgender. Gender affirmation. This is where the person being recognized or confirmed in a person's gender identity. Okay, they go through the gender expression. Now they're taking this a little bit further, and they are going to affirm that gender identity. And it could be, through medication, it could be through hormones, it could be through surgery. So they affirm their identity by making those outward changes. Sexual orientation. This is while one identifies their physical and emotional attraction to others. And there's three components, of course. There's attraction, there's identity, but there's behavior. So it is multifaceted. And being transgender is not the same as being gay. In fact, transgender people can be of any sexual orientation. Yeah. They could be attracted to those of their same biological sex. Opposite. So they can be of any sexual orientation. Okay, a few statistics here. About 7.1% of the US population identifies as LGBTQIA. Let me kind of just spell that all out for you, because this is another mnemonic, so to speak, that is constantly changing. The latest is LGBTQIA, L, lesbian. So it is lesbian, gay, bisexual, transgender, queer or questioning, intersex, asexual, or more. And that's what the plus means. Now, of that 7.1 population, 1.6 million people 13 years old and above identify as transgender. Okay, so the LGBTQIA, that's the big umbrella, but underneath that, you've got the transgender population is one of those subsets right there. And a recent survey was done, and it showed that almost 2% of US high school students identified as transgender. And 10% of high school students identified as gender diverse. So you can see this population is growing. It is continuing to grow. So what's the biggest issue? Well, this is, I'm going to call this a classic study, because there really have not been, more studies are coming out, but this I consider this a classic study. This was done by Bauer in 2009, saying that about over 20% of these patients reported avoiding the ED due to a perception that their trans status would negatively affect such an encounter. And those negative experiences were specifically related to being transgender. That was reported by half of them, over half of them. And about over half of that population of these patients reported actually having to educate their providers, some or a lot of the time. When we consider the majority of the percentage of transgender individuals, a large percentage of them are adolescent teenagers in their early 20s. The brain does not finish developing until you're 26. I have to tell my 21-year-old daughter that every day. So because of that, they're not healthcare professionals. They come to the ED looking for answers. And when they're the ones who have to teach the staff, that's like the blind leading the blind. Okay, so that's become a very, very big dissatisfaction with that. And avoid emergency care from the study because of fear. Number one, fear of discrimination. So they avoid care. And prior negative experiences. They avoid care. They had a bad experience in the ED or any healthcare encounter for that matter. It could be a clinic, it could be a doctor's office, in hospital, and they had a bad experience. They just do not go back. What's the problem with that? Well, the problem is that now it's we talk about the term physician heal thyself. This is more like non-physician heal thyself. They don't have the support. They don't have the guidance. There may be something wrong with them that they do not know. And because they are avoiding health care, it makes them even more sick. So that by the time they do end up in the ED, they are significantly sick. Okay, so this is one of the real dangers here. This is a real problem, guys. This is called gender-related medical misattribution and invasive questioning, also known as the trans broken arm syndrome. Now, what the trans broken arm syndrome means is that these are misconceptions on the practitioner or the provider as the cause of this patient's health problem. You know, there's misconceptions about that, and it can take on two forms. The first form is casual misattribution aspect. So this is in the provider or practitioner's mind. Well, their gender affirming status obviously has something to do with why they're here today. That's very biased. So that is one part of it, because they may not know enough about this type of care. They make a presumption that their chief complaint or injury must have something to do with their status. And here's the other one. One of the big reasons why these patients do not want to go back because of a prior negative experience, invasive questioning aspect. These are when the questions are asked about the patient's gender identity, their medical affirmation or surgical affirmation that are invasive, and they're not necessary in making that medical diagnosis about the complaint. The motto is, if it's not relevant, don't ask. If it's not relevant, do not ask. Keep the conversation clinical. There are exceptions to that, and we will talk about that here in a minute. So what are some best practices? Well, let's start with the first best practice. It's really about communication. How do these patients want to be addressed? Okay, so addressing the patient. You know, we're very used to, to saying things such as, oh, good morning, ladies. Thank you, sir. But, the huge impact can be made simply by saying good morning, leaving out the ladies, and thank you can make a huge, huge impact right there. Yeah, I'm used to saying sir. I mean, there's just things that are almost like a reflex, addressing. So ask their name or their chosen name. That is the recommended name or chosen name. Some people may have heard the term preferred name. That is not recommended. Ask the preferred name. In that patient's perception, well, their perception is, well, I have to make a choice now about giving them my correct name or my dead name, or giving them my, my chosen name. Simply ask them what they want to be called. That's all. I talk to a patient, they come in and I say, okay, your name's, what do you like to be called? Real casually, right? Introduce yourself. Pronouns, the power of pronouns. So when we talk about pronouns, you want to ask the patient what their pronouns are, not their preferred pronouns. For the same reason you do not ask about the preferred name. In their mind, well, now they have to make this choice about, do I have to give them my legal pronouns, which I was hoping I would never have to do again? Or can I give them the pronouns that I identify with, of who I am? Include your pronouns in introducing yourself. A lot of people do. There's a lot of, and I can tell you that on my email signature at Elsevier and a lot of people's, the pronouns will be underneath the signature right there. Everybody who works at ENA, I can tell you pretty much I've emailed everybody as their pronouns underneath their signatures at ENA. And I thought that was great. Hi, my name is Justin. My pronouns are he, him, and his. How can I best address you? That's showing that respect. And using the chosen name and pronouns is shown to be very protective. So it's really been associated with very, very good outcomes. In fact, there was a cohort study that was done that showed that collecting and using the chosen name and pronouns reduced depressive symptoms, suicidal ideation, and suicidal behavior among transgender youth. That's huge. Okay, that's very, very big. Simply by collecting and using the patient's chosen name and pronouns reduced those, because we'll talk a little bit here more about suicide and why that's a big issue. Gender neutral pronouns you've probably heard of, and they are always changing. There are lots of gender neutral pronouns that are out there. And this list that I've got could be completely different tomorrow. And not everybody uses them. You've got to ask. In fact, most transgender individuals are going to use the pronouns that they identify with. A transgender man is going to use he, him, and his. Transgender woman is going to use her, hers and she. That's what they're going to use. They, them, and their, it has now been accepted by the APA, American Psychological Association, as acceptable third person pronouns. In fact, at Elsevier, we're actually, the company is working to actually make all of the content gender inclusive by using they, them, and their. You're going to make mistakes. You're only human. You're going to make mistakes. You simply, you apologize and you move on. Because, if we don't ask 100% of patients 100% of the time, we're only going to further the stigma. Okay, so it's very, very important to be consistent on that. Now, when we get into injuries, I'm sure that most of you can take a gander at what most traumatic injuries are caused by in this population. And the unfortunate thing is that you're absolutely correct, and that it is going to be violence. And this is a picture taken from the horrific incidents at the nightclub in Orlando, Florida, several years ago. And it's a horrific event where several people were killed. Violence, that is the number one reason, cause for injuries. So they're most likely to be victims of assaults, intimate partner violence with them, suicide. And more than 60% of transgender population has been subjected to assault. And that's a big number right there. In fact, there were 27 deaths from violence that were recorded in 2019. 22 deaths from violence were recorded in 2020. Other risks are going to include behavioral health. That's going to be a very, very, it's going to be a very, very real concern. Anxiety, depression, lots of suicide. And I'll tell you all a little bit about gender dysphoria. Gender dysphoria is an uneasiness or an anxiety that the transgender person or gender diverse person feels because their gender identity differs from their sex assigned birth. Not everybody goes through this, but it's anxiety that they experience because their gender identity actually is different from their sex assigned at birth. The latest DSM-5 actually includes gender dysphoria as a diagnosis. It actually includes that for people whose distress is clinically significant and impairs social, occupational, or other important areas of functioning. And as I say, not everybody goes through gender dysphoria, but it's important to recognize that and to try to nip it in the bud. It can lead to that's the anxiety, leads to depression. The depression is not resolved, that leads to thoughts of suicide. And speaking of that, did you know that the transgender population makes up the highest percentage population of people who attempted suicide? Consider that highest population. Look at that, 82% of transgender patients, and that came out in only 3 years ago. 40% have attempted suicide. And these studies have also shown that these rates are even higher in the gender diverse, in non-binary and genderqueer individuals, even higher. Drugs and alcohol, another very big risk. Depression, drugs and alcohol. So what are the challenges as far as trauma? Let's take a walk down the initial assessment and talk about the primary and the secondary survey. Okay. The first thing I want to remind everybody is that the priorities of resuscitation do not change. An airway is an airway. Breathing is breathing. Circulation is circulation. The priorities are the same, period. There are things to consider, though. So let's take airway and breathing. Tracheal stenosis. Now I'm gonna another mnemonic I will give you up there. AFAB means basically an affirmed, affirmed female at birth, an affirmed male at birth. Tracheal stenosis is more common in affirmed females at birth because they have a narrower trachea. Right? And the estrogen actually will increase fibrotic scarring. So if this is a transgender female who is taking estrogen, that is a risk. We have to think about that. A difficult intubation in the transgender man. Remember how they went. Okay, in the transgender man, you may need a smaller tube with that. So that can be a difficult intubation simply because of that narrow lumen. Okay, a chondrolaryngoplasty or the tracheal shave. I don't know if any of you have heard of the tracheal shave, but this is essentially a surgery that the transgender woman will go through to shave down the Adam's apple. Right, they're going to shave down the Adam's apple. So they'll have that, they'll have that thyroid cartilage, just kind of resected down, just so it's not prominent right there. But you're messing with an airway. Okay, you're messing with thyroid cartilage. You're messing with an airway. So the complications from this can be painful swallowing, hoarseness, or laryngospasm. And it also depends on how recently they had the surgery. If they had the surgery just a day or two, or a week or whatever before they had the injury, you might be a little more concerned. If it's been a year, whatever, or whatnot, it's probably not going to be as significant. Gender affirming hormones. The testosterone can cause sleep apnea in the transgender man. Okay, so they're taking testosterone. That can cause sleep apnea. Circulation, gender affirming hormone therapy. One thing you have to remember about the two top hormones here, and that's going to be estrogen and testosterone, is they both can cause blood clotting. They can both cause blood clotting. In fact, testosterone not only can cause blood clotting, it can cause polycythemia. Okay, so that makes the cells all kind of clump together there, kind of like a clot. So for a trans woman, they're more at risk for a VTE, for a PE, an MI, or even an ischemic stroke because of that. Couple that, if they're in the hospital, on bed rest, and or they've had another procedure done when they're in the hospital because of the injuries. Yeah. Blood products. Now, in massive transfusion, everybody, most people are going to get O negative, right? They consider the the O positive for males, but they're pretty much going to get O negative most of the time here, pretty much all the time. But in less emergent situations, the type specific should be used. I mean, that's pretty straightforward with anybody. Right? Disability. To gender affirming hormones, remember they could cause blood clotting, and so we have to consider that in the events of a stroke. Also, if the patient is unconscious, patient comes in and their AVPU score is zip, right? Or their GCS is a 3. They cannot answer anything. This can cloud things. You cannot, first of all, you can't get their name and pronouns, and you cannot get a history. Why is that important? It's important because you may need to know whether this patient still has their reproductive organs, especially the transgender man. Did they go through the hysterectomy or not? And if you can't ask that and you don't know that, that's going to kind of cloud things. Expose and environmental control. This is big. Fear, discrimination, and stigma during healthcare encounters. So let's picture this. Here is this patient already scared of health encounters, and you've got about 7 strangers around them, all masked up, gowned up, and cutting that person's clothes off in front of a whole crowd right there. All right. That is very stressful. Okay, especially in a big crowd like that. Always take that into consideration. One person should really be kind of be the just kind of the communicator to that patient. Maybe just explaining to them what's going on. And one thing is to explaining as gently as you can, why the clothes have to be removed. For your safety, we have to see what other injuries that you have. But maintain as much privacy as possible. Sometimes in a busy trauma bay, that's hard to do. But as much as you can, you want to provide that privacy. Treat them with dignity and respect. I cannot say that enough. You want to treat them with dignity and respect regardless. And the findings that you're going to see on Expose, environmental control, surgical scars may be there. It could be surgical scars from top surgery if they had mastectomy, or scars from a hysterectomy, or scars from the bottom surgery. Not that you have to do anything, but that you would note them. Full set of vital signs and family presence. Baseline blood pressure and heart rate are often different between the affirmed male at birth and the affirmed female at birth. Think about that, right? The affirmed males at birth tend to have higher blood pressures. Right? So, with the hormones, just consider that it's going to swap. It's going to swap a little bit here, right? Because now that transgender woman is taking estrogen, that can lower it, and the transgender man is taking testosterone, that could raise it. See that, how it kind of crisscrosses like that. Family presence, that could be a source of stress. That could be a big source of stress. So the partners should not be excluded from the family presence. That's important. Okay. Don't exclude the partners. And you need that has to be the patient's choice as to who they want to see in there, because they're already scared. They're already in this situation, which makes them very anxious. Family members may or may not make that worse. And if they're victims of violence, those family members should be screened before letting them see the patient. And you always want to consider that, especially if there's been an assault involved. Okay, getting monitoring devices and giving comfort. So labs are LMNOP. This is important, and it's a very hard question to ask. It's a very hard question to ask. One of the ways that I like to say is, because your belly is hurting, because you're having some pain down there, it's very important that we ask you this, because if those organs taken out, it could be one of those organs that's actually causing the pain that you're having or causing the problem. You just gently kind of explain that to them. And of course, this is going to be a little more concerning in the transgender male, right? Explain the rationale for pregnancy testing. Well, I'm not going to get, well, for your safety, since you just told me that you do have your organs, we need to make sure, we need to have that test because of that. If they're going to get imaging, if they're going to go to the operating room, they're going to have that, right? Also, here's a little curveball. The transgender man, if they do still have the organs, may be menstruating, and that could put blood in the urine and cloud things. All right, that we got to consider too. If they're unconscious, they cannot tell you that. That can cloud things. Communication with the lab is very, very important. not everybody's lab values are the same. I'm thinking especially of CBC results and hemoglobins and hematocrits. Very different between affirmed males at birth and affirmed females at birth. So if this individual has lab sent and they identify as a man at birth, an affirmed man at birth, and the lab gets these labs and looks at them and goes, that doesn't make sense. Okay? They should be communicated with them. Some of those baseline values are going to be different. And if they run it into the machine like that, the machine's not going to want to run it. It's going to say error, right? And so they may need to have maybe a manual and actually written lab slip sent up to them. Monitor. Mastectomy scars may be noted when the lead placement is put on. Okay, gastric tubes. There's really no special considerations for this. I mean, unlike other trauma patients, if they got facial fractures, right, we're not going to be putting an NG tube in, right? But there's really no other special considerations. It's the same thing with measuring the O2 sat and the end tidal CO2. No special considerations there. Pain and pain management. Let's talk about that. Now, transgender patients often experience bias from healthcare providers. It's going right back to that broken arm syndrome, and they may not get adequate pain management because of that. Okay, so it's important to really, really be the patient advocate here. Okay, so they can result in inadequate pain management. There's actually an article that was written about that. The history. Keep the conversation clinical. Curiosity really did kill the cat. All right. Keep it clinical. Don't make it personal. They're gonna be scared to talk in the first place. And as I keep reiterating, it's not pertinent. Don't ask. Now, why would I ask about their gender status and medical affirmation? Well, there are some exceptions for that. A transgender man with abdominal pain, like I had mentioned before, because if that patient had abdominal pain, especially lower, and had not had a hysterectomy, oophorectomy, salpingectomy, that could be the reason for the pain, right? That could be part of the injury. So that's going to be an exception. Not a trans man or woman with a sprained ankle. There's no need to ask about that. If they've got something like a sprained ankle, a laceration, a head injury, there's really no reason to ask about their medical or surgical affirmation. Asking about reproductive organs and their pregnancy status, as I'd mentioned before, for imaging, it's got to be in preparation for surgery. Those are kind of two big exceptions right there. The head to toe assessment, head and face. No real special considerations, but with the neck, the tracheal, I put those two T's there. I didn't mean to, that's a typo. But that tracheal shave scar. Okay, they may have that tracheal shave scar that you notice, the chest. They may have had a recent mastectomy or a mammoplasty. The abdomen and flanks, a recent hysterectomy. That's important. That's important. Goes right along with, especially with the transgender man. They could have had a recent phalloplasty, and they may have a suprapubic tube. Now, the phalloplasty is the male affirming surgery that the transgender man will undergo. It's a lot more complicated. And so they've had the phalloplasty done. They very often have to have a suprapubic tube for several weeks, for at least a couple of weeks. They have to have that. So that's something you'd maybe want to expect. But it's important to know if they've had the phalloplasty, if there's any significant trauma to the abdomen, flanks, or the pelvis, because that would be concerning and something we would want to know, right? The pelvis, right? If there's a significant pelvic fracture, there's a urethral injury. And if this patient has had a phalloplasty or a vaginoplasty, which very, very much involves the urethra, that could cause complications. Higher risk again if they've had the phalloplasty or the vaginoplasty. And of course, that can worsen gender dysphoria, worsen depression. Think about that. They're scared to be there, and now we have a problem there. That can really, really get them in that dysphoria. The perineum, there's unique anatomy following gender affirming surgery, that they may have a phalloplasty. There's excellent jobs that are done, but you kind of know that it's not, you kind of know that it is, how can I put it, surgically attached, so to speak. So that catheter may be contraindicated. If they've had a phalloplasty or the vaginoplasty, they may have a suprapubic tube in place. The extremities, skin grafts for the phalloplasty are often taken from the forearm or the inner thigh. It's kind of like a distinctive, it's like it's a distinctive scar. So if the patient's got this big old, graft scar on their forearm or maybe their inner thigh, that's very, very typical of where they got the graft from to do the vaginoplasty or the phalloplasty. Inspect the posterior surfaces again. Unless it was a gunshot wound, like with other trauma patients, a stab wound or penetrating trauma, there's no special considerations here. Just keep reevaluating. Let's talk about that. Psychosocial status is huge. Okay, that is huge with these patients. Gender dysphoria, I mentioned that before, that distress or discomfort due to gender identity differing from that sex assigned at birth, both physically and socially. And it can lead to depression and thoughts of suicide. And not all, now TGD stands for transgender or gender diverse, okay? Patients that I said they don't always experience that, but you want to maintain continuity of care. Not only in the trauma bay, but up in the unit, up in the ICU, up on the floor, in the operating, right? In rehab, inclusive, supportive, and caring. It's so basic, guys. American Psychological Association says the people of diverse gender expression should be afforded the same respect and rights as those whose gender identified expression conform to societal expectations, right? And I'll quote American College of Surgeons fellow Elizabeth Bugler, who said that, as trauma surgeons, we strive for that optimal care, attending to those physical, psychological, and social needs. And the review that they did considers critical issues to consider when caring for transgender patients should be included in educational programs for trauma, fellowship training, and used as a resource to raise awareness in our trauma centers. And it is. American College of Surgeons and East are 100% on board with this. ENA is 100% on board. In fact, I'm going to give you a spoiler alert right here. The 9th version of TNCC, which is due to come out in August, has another special populations chapter of, wait for it, the gender diverse or transgender patient. So it is happening. You want to lead by example. You want to lead by example for these, and lead by example for your team members, for the family members, right? Now, I've had such a passion about this, for years. It's been a very, very big interest of mine. And people are, well, Justin, why does this interest you so much? Why is this so interesting to you? Well, it's because of this guy right here. He has shown me so much, and has taught me so much, going through his journey, that both his mom and I are just super proud of him. And the wonderful person that he's become. He has gone through his challenges, and he, all through school. And he persevered. He definitely persevered. And right now, he is in his final clinical year of veterinary school at Cornell, up in Ithaca. He is very happy to be there, very, very proud to be there, and very, very excited for that. Here's some of the references that I used, but you can always email me that. And I will take questions, but I'm also going to put up, there's my contact information. If you would any of you would like to email me, ask me any questions about that, that'd be great. And I do see some questions in the chat. Let's see here. Okay, there we go. And they're all from you.
And now's an opportunity to say if either Bobby or JC, if you have any comments, if you want to type them out in the chat box, that would be great. Or you want to unmute yourself, then absolutely feel free to do so. From my perspective, Justin, very enlightening tonight. Just when you think you kind of had your hands wrapped around, these special populations, you just find that there is the tip of the iceberg. So you've definitely illuminated kind of that below the waterline that I think really makes those of us that are taking care of these patients extremely anxious. How do we approach them? What do we say? What is appropriate and what is not? So from my perspective, very enlightening. And this is after having read your manuscript and going back and forth with you over your manuscript. So,
which I did use to make some of this content. So.
Absolutely. We've been disappointed if you hadn't.
All right.
All right. I'm going to pull back from you, reclaim host.
Yep. I will stop sharing.
Excellent. And then I'm going to throw up something very quickly here. Let me go back to my screen share. And let's see, we'll find hopefully the right screen this time. Boom, boom, share it out. And we already kind of went through this information. Oh, you're gonna, nope, don't, nope. Okay, perfect. So like I said, wanted an opportunity to have an open forum here. So, once again, we've got a quote there, very informative from JC. So thanks for popping that up there. Absolutely. You have Justin's contact information. So absolutely feel free to reach out to him if any questions you have. Justin is very responsive to emails. Every time I've ever emailed him, I get a response post haste, and that's always appreciated.
All right. Perfect.
So I put in the chat box, I put information with regards to a link to go to SurveyMonkey for both Bobby Jean and JC to claim credit for tonight. As I said in the beginning, I'm going to, once I render this and get this up on YouTube, which will probably be a couple of days from now, we'll give about a week from that time for, anyone that you want to kind of pass the link on to, and or other people that kind of signed up for tonight, but for various reasons couldn't be here, but they'll be able to go on and at least claim some credit after the fact. So please do take advantage of that, and also just please provide feedback. Your feedback is important in that it certainly affirms Justin's hard work in being here tonight. It also gives you an opportunity to provide me some thoughts on topics that you might like to see moving forward in the future. As I had mentioned, the next session of this will be on September 6th. The QR code up there will provide you a direct link to be able to register ahead of time for this next session. Again, it'll be on the shock index, emerging tool for occult hemorrhage and trauma. And then the other QR code, because I am QR code crazed lately, is to the YouTube channel, which houses all of the sessions for both topics in trauma nursing as well as the Trauma Nursing Journal Club. So if nobody else has any questions, definitely I thank you for your time. And more importantly, Justin, I absolutely thank you for your outstanding talk tonight. And again, congratulations on the affirmation you got from the Journal of Emergency Nursing yesterday that your article is going to be published. Hopefully we'll let you know how quickly that'll be done. Optimistic that it'll certainly be probably in one of the fall issues. They do try to get these.
And I actually will be speaking at ENA this fall, specifically on the complications of
Phenomenal.
these procedures that can end up in the ED.
Well, consider me already signed up for it. I actually completed my registration today, and after I put my eyeballs back in my socket, is how expensive a hotel is in San Diego.
Oh my!
So it's good to know we'll be able to kind of meet up for a drink in person in San Diego, which is always a good time.
You bet.
So, okay, excellent. So if there's no other questions, then we will go ahead. So I'm going to go ahead and stop.
I have a question for Justin.
Go
Yes.
for it, Bobby G. Go ahead. You
I'm
just
here.
muted yourself again.
Can you hear me?
Yep.
I can hear you.
You keep muting yourself after you talk. Do we have to get your dog up to teach you how to use this? Hit your space bar if you're using your computer.
I am
There you
on
go.
my space bar.
Okay,
go.
there you go. Now we got you.
Okay, I worked in an emergency room where a couple of years ago, in order to make an attempt at being all inclusive,
Mhm.
they had these forms, which I believe it was prior to triage. It was where our concierge nurse
Mhm.
greeted the patient,
Mhm.
and the patient was supposed to fill out their identified name and identified pronoun and identified gender, and that was how they worded it.
Okay.
And our patients who were older than 40 became very offended by it and wanted to know what this was and why it was there. What is your recommendation on dealing with a population that is not into, for lack of a better word, dealing with transgender or any of the other alphabet soup that we are currently using today?
That's a tough question, and it's going to continue. My answer to that is as far as we are concerned in this institution, in this emergency department, every single patient who walks through here deserves the respect and dignity. And by asking those questions, we are showing this population that respect and dignity. I'm sorry if you find that offensive, but we respect you when you come through. The simple answer is we respect everybody's gender identity, and we respect every patient who comes through here. It's simple, because you're not going to change a lot of these people. Unfortunately, I live in Texas. I mean, we've really got it bad here. So, and my wife's a pediatrician, and she's been fighting this with me forever. So,
I think Texas has their own set of issues, I think.
yep. Oh yeah, they do. Texas and Florida. Yeah.
Countries onto themselves at some points in time, right?
But again, that is a very, somebody else brought up that question to me the other day. And well, first of all, if more and more places are not using the forms to fill out, it's really going to be more asking the questions and putting that into the EHR to maintain that privacy, which probably is the best way to do that. In one of my other presentations, I actually make a point of using those forms. I put a form out. I found one in, I was taking my mom to one of her doctors, and she was filling out the form, and it next to sex, that's outdated already, and it had 3 choices: male, female, or transgender. And so what I asked the people is, okay, if a transgender woman comes up and fills out this form, which of these 3 do you think that she's going to fill? Which of these 3 do you think she's going to check? She's going to check female.
Yeah.
They're going to go with who they identify as in that term. Why? They don't like being called out. That form is checked transgender. We pass that on to somebody else who's going to be doing the insurance and bill, then it's passed on to the nurse, then it's passed on to the x-ray tech, then it's passed on to the provider. That's a lot of passing on. So you know, the best practice is to be, you know, is to as much privacy as possible. And that pretty much means doing away with the paper and just entering it into the EHR.
I think that that's one of our biggest problems we come up with is maintaining that privacy across the board, not
Yeah.
just in this issue,
Right.
but in not telling the X-ray tech, did you see what happened? Did you see what was on that? So I think that's a good point, that if we don't have the paper, there's one less trail to follow.
Exactly, and you've maintained that privacy. And I'm, you know, more and more, you know, especially you see these in physicians' offices and clinics and whatnot, where they may still have the paper trail going on, but more and more, you're just not seeing it anymore. You know, it's strictly going to be paperless, and therefore more private.
Well, thank you for your presentation. I appreciate it.
Well,
Absolutely.
you're welcome. Thank you.
Thanks for being here, Bobby. Always appreciate it. Justin, thank you for your time tonight. And I look forward to meeting you in person in San Diego in just a few short months.
All right, I will see you there.
All right.
Bye-bye.
You guys take care. See y'all later.